thing is, if possible, please do not interrupt in between unless he is making a gross mistake. Let him complete the history, followed by we'll be asking questions, and then we start with the examination and the investigation thereon. Right,
Okay.
sir?
Okay,
Yes,
Apurva,
sir.
have you interested? I think madam has joined, I think.
Yeah, yeah. Vijay ma'am has also joined. Good morning, ma'am.
Good morning.
Sorry, I
Good-
Are
didn't
you
see you,
able to
ma'am.
hear?
Loud
Yeah,
and
yeah,
clear.
sir. Yeah, ma'am. Absolutely, absolutely fine.
Yes,
So
yes.
Welcome, madam. I am Dr. Pankaj Modi, welcoming you from on behalf of our association.
I want to see.
so I am really grateful to all of you to have joined on a Sunday morning for academic cause. We are joined by Dr. S.K. Vittal, sir, who is not unknown to anybody in the field of endocrine, and he is an adjunct professor at Tamil Nadu and MGR Medical College. We have Dr. Urvi Parekh, who is a consultant endocrinologist in Ahmedabad. We have Madam Vijaya Lakshmi. She is an ex-HOD at and director at MMC, and at present she is a professor at ACS Medical College, Chennai. We have Dr. Rajpal Gopal Shinoy, sir, who is a professor at Kastuba Medical College, Manipal, and Dr. Neena Ben, who is our own faculty at Ahmedabad. We also have our lifeline, Dr. Pankaj Modi, sir, who has always been with us for a long period. Sir, we'll start then.
Okay, just one more thing, Apurva.
Yes,
Just
sir.
for that, all PG must know Dr. Sinoy. His book everybody must have read. It is so good, particularly thyroid part. I would recommend even after completion of this. Thank you very much. Let us start.
Good morning, everyone. Myself, Dr. Rohit Sharma, third year resident from BJ Medical College, Ahmedabad. I am presenting a case on thyrotoxicosis under guidance of Dr. Pankaj R. Modi, Dr. Apurva Shah, Dr. Maulik Mehta sir, and Dr. Vineet Chauhan. History. I am presenting a case of 31-year-old female patient, resident of Bhavnagar, belonging to low socioeconomic status, presented in OPD with chief complaint of diarrhea for last 4.5 years and swelling in the neck for last 4 years. Onset, progression, and duration. Patient was relatively asymptomatic 4.5 years back when she started having diarrhea, 4 to 5 episodes per day. There is no blood or mucus in stool, with weight loss of 18 kg in last 4.5 years despite good appetite. Patient also noticed swelling in the neck 4 years back, which was gradual in onset, slowly increasing in size. Swelling is not associated with pain, shortness of breath, dysphagia. Patient is also complaining of perspiration and palpitation for last 4 years. Complain of intolerance to heat, hair loss, and decreased sleep for last 3 years, and complain of bulging of eyes since last 1 year. There is no complaint of sudden increase and decrease in size of swelling, lethargy, shortness of breath, change of voice, fever, stridor, headache, and watering of eyes, and diplopia. Patient went to the physician for above complaint and started on tablet, which was given 3 times per day, and patient had improvement in symptoms after starting medication. But patient was irregular with the treatment and took medication for 4 years, for 2 years, and after that, patient stopped taking medication, and after stopping the medication, patient symptoms appeared again. Currently, patient is not on any medication. Past history, there is no history of any radiation exposure, surgery, hypertension, diabetes, allergy, tuberculosis, or asthma. Menstrual history, patient is married for past 6 years. Patient is nulliparous, amenorrhea since last 2 years. Before that, patient has regular menstrual cycles. Personal history, patient consumes vegetarian diet with iodized salt. There is increase in appetite and decreased sleep. There is complaint of diarrhea, and urinary habits are normal. There is no addiction history. Family history, there is no similar complaint or history of thyroid illness in family. Summary, 31-year-old female patient having complaint of diarrhea and weight loss with since last 4.5 years, with progressively increasing neck swelling along with features of hyperthyroidism without any features of change in voice, dysphagia, dyspnea, without any significant family history and comorbidity.
Okay, sir, please let us discuss history part.
Start with the first slide. Okay, fine.
Fine. Sir.
Shinoy, sir. Srinivasan, sir.
Yeah, Rohit,
Yes, sir. Good morning, sir.
good morning. Just completion's sake, one or two things that it's always better to put the slide numbers, so that we can always, ask you, show the slide 3, show the slide 7, like that. Doesn't matter.
Yes, sir.
Having written that 31-year-old female from such a city presented to the hospital with the following complaints of diarrhea. Anyway, having written there, please make it capital. Anyway, that's different issue. Now,
Yes.
so you have given more details about the diarrhea there. So that is her main complaint, correct?
Yes, sir.
So now tell me, was it associated with the pain or painless? Next, you can show the next slide so that,
So it was
yes,
painless.
correct. See, go ahead. See, what I'm trying to tell is, I know today your case is straightforward case. There is some thyroid swelling, there is a diarrhea, there is a, so go back just. So just to keep you informed, when the question of diarrhea comes, you should always remember.
Yes.
Suppose I ask you the question, why not it is, say, inflammatory bowel disease, or why not it's Crohn's disease, why not it is tuberculosis, you should be able to give an answer for my questions.
Yes, sir.
Tell me,
So
how do you rule out one by one?
in case of
Well, I know you are prepared for this, no problem, but you should be keeping mind open. Yes, tell me.
in case of inflammatory bowel disease, in
Yes.
ulcerative colitis, there will be complaint of mucus or blood in the stool, along with
Yes.
increased frequency of stools.
Yes. They can also have some remissions in between, remissions.
Yes, sir.
This also, we are dealing with the thyrotoxicosis case today as per this. So always it is associated blood and mucus. Now with or without pain abdomen, that also should come into the discussion.
Yes.
Multiple ulcers in the rectum, colon, all they can also give rise to diarrhea. So
Yes.
did this patient ever had any pain abdomen?
No, sir. There is no complaint of pain in abdomen.
So what do you think the cause for this diarrhea in relation to the neck swelling?
Sir, it could be due to diarrhea due to the hyperthyroidism. There is increase.
Any other? Suppose I ask you the question, can some malignancy of the thyroid can give rise to diarrhea?
Sir, medullary carcinoma of the thyroid can lead to diarrhea.
So these are the things, because you have only mentioned neck swelling in this patient, correct?
Yes, sir.
Now this about the diarrhea, I just want you to know that diarrhea, dysentery, details should be expected, with or without pain, with or without blood, with or without blood and mucus. That is the details we expect. Now,
Yes.
You didn't think of malignancy?
Sorry.
You didn't think of malignancy?
Yes, sir. It could be due to malignancy.
What made you to rule out malignancy? If the patient didn't present to you with the thyroid swelling,
Yes, sir. So
only
there was.
yeah.
So
Only
there was
the-
also associated feature of hyperthyroidism, like palpitation, weight loss, perspiration, hair loss, and complaint of lack of sleep, along with the diarrhea and the swelling of the neck.
4.5 years, can a patient with malignancy be without any other extra colonic manifestation? No, I'm giving you a picture. The patient doesn't have a swelling in the neck.
Yes, sir.
Will you think of malignancy also?
Sir, I think just now we mentioned already medullary carcinoma thyroid, sir.
No, I said if the patient didn't present with a...
Didn't present.
That's what I'm asking, sir. So left colonic malignancy usually have what else?
Yes, sir.
What will be the symptoms of left colonic malignancy?
So left colonic malignancy present with the obstructive features.
So alternative bowel habits will be there. Okay.
Yes, sir.
Okay, proceed.
Madam, Vijay ma'am, you need ask anything?
Yes. Why do you want to put the diarrhea as the first complaint? Patient has only complaints of diarrhea, or is it the swelling which she has come from? The patient has come.
Patient presented to the OPD with complaint of swelling, but patient also had before that diarrhea, complaint of diarrhea before that.
So that is a long history.
Yes.
Area. This swelling is also of a long period. And you want to put that first or this first?
To put a complaint in chronological order, I have put the diarrhea as the first complaint.
So what is a typical characteristic of diarrhea? Dr. Neena here.
Good morning, madam.
Good morning.
Diarrhea is liquid in consistency. It occurs 2 to 3 hours after eating food, and there is no complaint of any pain abdomen, and there is no blood or mucus in the stools, ma'am.
But my question is, what will be the specific complaint in diarrhea? It is unexplained diarrhea, specific in thyrotoxicosis, right?
Yes, ma'am.
Madam, continue.
Yes, you can cut.
Rohit, why diarrhea occurs in thyrotoxicosis?
So diarrhea occurs due to the hyperexcitability of the ganglion cells in the intestine, due to the sympathetic, due to the increase in the T3, T4 hormone and increased metabolism.
See, anxiety, irritable bowel syndrome, carcinoids, medullary carcinoma, in addition to the thyrotoxic, all will produce. That's why madam was asking for beginning, patient has a complaint of diarrhea first or the swelling first. I know you said that patient presented with a diarrhea first, but remember, you can use your, I'm not trying to say you should say manipulate, but it is more looking sensible. Many of the time, patient might not have noticed the swelling. You understand, no? So keeping that in mind, that will go for swelling and diarrhea in that order. I think so, right?
Yes.
Rohit, why symptoms appear first and the swelling patient notices later on, as the sir has said specifically? How will you explain it?
Sir, due to the increase in the thyroid hormone T3, T4 hormone, patient present with the symptoms of thyrotoxicosis, but swelling is commonly noticed by the relatives of the patient, and it is not big enough in size to be noticed by the patient. So symptoms of thyrotoxicosis.
No, that is you are just stating the obvious. I am asking you why the symptoms will be first followed by swelling. Noticing by relatives is not the answer. What is the reason why? What does it mean when the symptoms appear first and the swelling is noticed later?
So it is due to the primary thyrotoxicosis, due to Graves' disease. If swelling appears first and symptom later, then it
why?
will be...
That is the question. Why so? That is again obvious. Why the symptoms appear first, followed by swelling? So what is significance of that? When you say symptoms appear first, followed by the swelling, what is significance of that? By the way, he's my resident.
Come on, yeah. So you just say, no, circulating hormones would have already started working. No?
Yes.
That's the answer, no? Correct, no, sir? Yes.
The point here is that it is an important symptom to differentiate between primary and secondary hyperthyroidism. So what happens in secondary hyperthyroidism, or what you call toxicosis?
In secondary hyperthyroidism, so swelling appears first, and
why? Again, the answer, I don't state obvious.
It is
why? That is the answer question.
So
this is an important point.
Basic pathophysiology, yeah.
Longer duration of the swelling, na? So because of the what? Fluctuating levels of some hormones will go on stimulating the gland. Gland become big and slowly later toxic. What is that?
He doesn't know, in spite of the thing. The point here is that in a primary hyperthyroidism, there is no pre-existing goiter. Patient doesn't have a goiter. initially, because of the mechanism, we'll discuss that later, circulating thyroid antibody. It will cause the increased level of T3, T4. So initially, T3, T4 level increase is causing the symptoms of hyperthyroidism. Over the period of time, due to overwork, there will be hyperplasia of the acini, which gives rise to gradual swelling. So symptoms appear first, swelling. In secondary word itself suggests that patient has a pre-existing euthyroid goiter. Initially, it may be diffuse, later on become nodule, and nodule, one or more nodule may escape from the control of TSH and start producing high level of T3, T4, and that give rise to hyperthyroidism. So that's why there is already existing swelling. So usually in secondary hyperthyroidism, there will be pre-existing swelling, which later on convert to hyperthyroidism. Whereas in Graves' disease, it is only T3, T4 level increases first, followed by secondarily swelling. That is the rough explanation. Sorry, I have some work going on in my home, so I will not be.
Vittal sir, your input, sir. You are muted, sir. Sir, you are muted. Yes,
With
sir.
regard to the history so far, I think my colleagues have done the needful already. They have pointed out all what has to be said. I would generally, I've always mentioned, you don't need to say dysphagia, shortness of breath, change in voice. I would use the word pressure effects. When you use the word pressure effects with regard to the thyroid, it looks more refined, but obviously it varies from examiner to examiner. Few words about primary and secondary. I thought I will not venture now, but since Dr. Pankaj Modi had to go and he has just mentioned it, I think that in primary thyrotoxicosis, it is the symptoms and the goiter appear more or less simultaneously. That is, it doesn't mean the symptoms appear first and the goiter appears 3 months later. It is more or less peripasso. That's the word we use. The symptoms and the goiter appear more or less at the same time. Whereas in a secondary thyrotoxicosis, in a long-standing goiter, toxicity supervenes. That is secondary thyrotoxicosis. I know we're only discussing history, but we'll just complete this. Next, if you take primary thyrotoxicosis, it occurs mainly, it is not only an exam, it is also a teaching session. So whenever appropriate, we'll introduce the concept. In primary thyrotoxicosis, it usually occurs in younger individuals, younger females. In secondary thyrotoxicosis, it occurs in older individuals, slightly older individuals. In primary thyrotoxicosis, usually occurs in iodine sufficient areas. In secondary thyrotoxicosis, usually in iodine deficient areas, because in iodine deficient area only you have multinodular goiter and so toxicity supervenes. In primary thyrotoxicosis, you have prominent eye signs, which is classical. 25% of primary thyrotoxicosis will have eye signs. In secondary, you will not. Whereas in secondary, it is a cardiovascular manifestations are more prominent. In primary, the CNS manifestations are more prominent. More importantly, in primary, it is regarded as autoimmune. They said about the antibodies, whereas secondary, it is not so. These are some of the few salient differentiating factors, and why you might notice the goiter a little bit late in primary thyrotoxicosis, because the symptoms and the goiter appear more or less simultaneously. Sometimes because the thyroid gland has to be enlarged 2 to 3 times more before you palpate it. So you might notice it later. 2, thyroid swellings are generally painless, so you won't notice it. These are some of the things I thought I will share with you. Please carry on. I hope my colleagues agree.
Yes, sir.
Yeah.
Absolutely fine. Thanks for the input,
Rohit,
sir.
just want to add you that please don't mention pain in the beginning only for thyroid. Okay, it is one of the rarest of rare symptoms.
Yes.
Hardly, thyroiditis or bacterial thyroid, they're very, very rare. So pain is not a feature in the initial part. So you should not. Shortness of the breath means, what did you understand? Shortness. See, what do you think? Suppose the patient has got a goiter. What are
Yes,
the different ways in which patient can become breathless? Can you guess?
sir. Due to the pressure symptom.
One is a long-standing goiters. What is it? Happens to the tracheal cartilages. Generally, they become soft. The manifestation may happen post-operatively. One is the compression. That's what has been, sir has told, mentioned, pressure effects. Anything else? Suppose you don't see the thyroid swelling in the neck and patient is breathless due to thyroid swelling. What do you suspect?
Sir, in case of long-term thyrotoxicosis, there can be heart failure due to that.
So that is a very important thing with pedal edema, short of breath, what you are talking.
Hypercirculatory state.
Yes. You can also have a retrosternal goiter with some postural, when they turn to one side, there can be a compression on the trachea. So these are some more things expected. So pain should not come at this stage. Okay. We can proceed next.
I think you can carry on.
Sir, I have one just for a point of discussion. So this is a very typical thing which happens in many cases of hyperthyroidism. Whether he should mention simply medication or can name it. Because this is a very tricky one, because most of the patients who had a hyperthyroidism will come with some kind of treatment being taken.
He can mention, sir.
Yeah. If I was the examiner, I won't mind, because as a history, in fact, it's a pointer for you. He's helping you in your diagnosis. Why should we lie? Patient is saying this is the medicine I'm taking. So there's nothing wrong in mentioning what the patient says.
Because he did write that, but I said, let us talk on the tablets only, because the many patients are not educated. Because that is that. So, Rohit, which kind of tablet she might be taking?
So, patient was taking tablet neomarcazole 3 times per day for last 2 years.
You should talk like a qualified person. How many milligram? You have not mentioned. You're talking like a patient.
So, patient was taking tablet neomarcazole 10 milligram TDS for last 2 years.
Okay.
So in our country, this is quite common, sir. Either it's in toxic cases, this neomarcazole, and non-toxic. Many of them even keep thyroxine in their bottle.
But even in nodules, physicians are very fond of giving tablet thyroxine.
You can also mention, because it can be a drug-induced thyrotoxicosis for all that matter. So it may not be in your patient. I'm just trying to tell you. So overdosing. In an attempt to reduce the nodule, somebody would have put them some 100, 125. It goes on like that. And they keep those tablets, show us, this is what I'm telling. Now I'm getting palpitation. So I think drug history can continue.
Can we go to the next slide, please? Why do you want to ask for history of radiation exposure?
Sir, if there is a past history of radiation exposure, which can lead to thyroid malignancy, as patient has presented with the thyroid swelling.
What thyroid malignancy?
Sir, papillary carcinoma of the thyroid.
I would say no history of ionizing radiation, especially in the childhood, because there's a latent period,
Sir.
It's many years. It just doesn't come suddenly. Okay. Sir. And usually, this is nothing to do with this case. Usually, those kind of cases, the malignancy is aggressive, generally multifocal in nature. So no history of ionizing radiation in the childhood means the examiner knows this is an intelligent fellow who knows what he is talking. We should not bullshit with him. We should be guarded. You're telling the examiner, I'm knowledgeable. I know what I'm doing. I know what I'm talking.
Yes, sir.
Carry on.
Vijay ma'am, anything from your side?
Yeah, just want to ask at the end of the usual question, which examiner asks you is, what do you suspect now? Primary thyrotoxicosis or secondary thyrotox? These are the two common conditions.
Yes, sir. I am suspect.
Sir, sorry to disturb you.
Sorry.
There is a one lot of controversy going on. That's why I've said. So what is the reason for amenorrhea in a thyrotoxicosis?
Reason. Sir, you're muted, sir. Pankaj Modi, sir.
Yes, sorry. Because some working going on my home, so I am just keeping like that. You must be hearing in background. That's why I am keeping it little. The question is why there is a amenorrhea, or will there be excessive menstruation?
Usually, thyrotoxicosis or sorry, hyperthyroidism is associated with oligomenorrhea, whereas gross hypothyroidism is associated with menorrhagia. Perhaps in this case, the thyroid levels are so high that oligomenorrhea has become amenorrhea. That would be my logical explanation. I stand corrected by my colleagues.
Yes, sir. You fully agreed, sir. Because the thing is, effective estrogen level decreases. Effective estrogen means at the ovarian level because of the some alteration in the steroid levels which happens which in case of thyrotoxicosis. That's what they say explanation for oligomenorrhea.
I
Right,
think
sir?
we should pick the brains of a medical endocrinologist over here. She'll be
Yes.
able to guide us. Ma'am,
Urvi, Dr. Urvi, I think she must be bored.
Urvi
that is
ma'am,
why I said we have to pick up brains.
Ah, because this has I am also very exactly I don't know, to be frank, why there should be amenorrhea.
Usually it's oligomenorrhea.
Oligo, yes,
Usually,
exactly.
yeah.
Sorry,
But I
stand
think this
corrected.
is a very severe, long-standing, severe, untreated case that oligomenorrhea is amenorrhea. That's what. Nothing much to it. I'm not anxious about amenorrhea, but definitely this is the explanation I would give.
There is another question because I went through his side and I had certain query I wanted to discuss. The second point is it necessary to say about radiation?
Because you have got
Past
swelling,
history of
because you have got swelling in the thyroid, it is always good to say radiation. Point number one. Point number two, even toxic goiter, 5% of cases may be associated with malignancy of the thyroid. Graves' disease can be associated with papillary carcinoma of the thyroid. Different studies have shown incidence between 2 to 10%. So with the swelling of the thyroid, I'd always say history of ionizing radiation irrespective of the functional status.
thank you, sir. Very clearly said.
In fact, we have encountered many patients of toxic goiter with papillary carcinoma of thyroid in our own personal series.
Did operate before 1 year the same, a young female of 22 years. I was very sure, and it was a Graves' disease, everything, your antibiotic body and everything was fitting. Post-operative turned out to be a micropapillary CA. So yes, it does.
Yeah, the T3 and T4, high levels of T3 and T4, what happens? It stimulates the thyroid, causes papillary hyperplasia. Hyperplasia times malignancy. Same component. Same, it is just completion of the sequence.
Similarly, in personal history, I have a query. He has written, I have kept it like that. It is good to say patient is eating iodized salt in personal history. Sir.
I think it is good to say because now at least we know that the patient does not have symptoms of iodine deficiency generally. And as I told you earlier, in primary thyrotoxicosis or Graves' disease, more commonly occurs in iodine sufficient areas, whereas in iodine deficient secondary thyrotoxicosis generally occurs in iodine deficient areas. So nothing wrong in saying iodized salt. You're telling the examiner, first of all, you're stating the obvious. This is history. You are telling what the patient is telling. So nothing wrong. Two, scientifically, you're also telling the examiner that the patient, I do not think, suffers from iodine deficiency because patient is regularly consuming iodized salt.
Sir, this in 30 years back, it used to be common like this, whatever statement, sir. Because nowadays, I'm dealing in our practice here, because every salt is iodized salt, whatever most of the patients. So that is one of the reasons we say consume whatever diet, normal diet, over vegetarian, non-vegetarian. But as it's told, it is relevant here because we are talking about thyroid. So yes, sir.
One small thing, sir. Probably 10 years back, we'll just say salt. Nowadays, it is a fashion. because I will tell you the reason. You know, all our lay people also start reading Google scientific literature, and they know that consuming iodized salt sometimes can lead to autoimmune thyroiditis. I see patients saying, I'm consuming rock salt, I'm consuming all kinds of salt. So patients are sometimes more knowledgeable than the doctors. Sometimes I feel I learn from my patients. If I don't know, I go and refer. So they say, when they come to me, sir, I'm taking pink salt. What is pink salt? I have to ask them. So I mean, obviously, I am always fond of telling, as a candidate, when you sit for the exam, your aim is to pass the exam. Knowledge takes the back seat. You will have to dance to the whims and fancies of the examiner. So just tell what the examiner wants, and different examiners are different. So you see you see the reaction. If the reaction is happy, continue. If the reaction is as though they're upset, just change track. Our aim is to pass the exam. Never argue with the examiner. The examiner is always right.
Sir, same thoughts I told him only yesterday.
You see, sir.
Look at the Vittal sir, whether he is happy or not.
My looks will deceive. Even if I'm upset, I look happy with the candidate.
Yeah. The point is there. A point is very well taken. I always tell all students that passing an exam is a totally different thing.
Sir, I have known prize students failing in MS exam.
Exactly.
MS, he has got a prize before there, and he has failed because sometimes they are over enthusiastic. They think they are more knowledgeable than the examiner. They might be, but you should not show off. You are not there to show off. You are there to pass the exam. You are there to satisfy the exam. That is why if you take the FRCS exams, when they give the FRCS degree or the MRCS, they'll say you're satisfied the examiners. Don't think too much. You're just satisfied the examiners, they'll say. Continue,
Okay,
sir. We are digressing.
Yes, continue. Okay.
On this point, Rohit, I have one question. Which
Yes,
other
ma'am.
food can be utilized for adding the iodide?
Ma'am, seafood.
No. For giving the iodide, supplementing the iodide, we use the salt. Which are the other foods in which you can add?
Ma'am, in flour and in the oil, ma'am, vegetable oil.
And water. And water. Okay.
Is there an endemic area still prevailing in India? Got
Along the Himalayan belt.
No, I'm asking.
That is traditional. Sir is asking updated iodine thing. I think it is decreasing. Maybe we should do epidemiology study, but I still feel there may be pockets here and there. Whatever said and done, in hilly terrains, there's a higher chance.
Why? Rohit, why it is more common in hilly area?
Hello. Sorry to disturb you, but my voice was not coming. Now it is audible.
Yes, ma'am.
Okay. Yes,
Okay.
great. Please
Okay.
give your input. We were waiting for it. Yes.
Yeah. We were discussing about the amenorrhea in thyrotoxicosis at that time.
Amenorrhea in thyrotoxicosis.
Yeah. So that may be due to the pituitary disturbances of the hormones related to FSH, LH due to the TSH going low, and that's why the amenorrhea or oligomenorrhea may be there.
So will it be the same in secondary hyperthyroidism?
It will be the same in the secondary hypothyroidism also.
It is not the cause. It is the thyroid hormones excess. Whether it's primary or secondary, you will have oligomenorrhea, maybe in drastic cases amenorrhea. Irrespective, it is only the high T3 and T4 with the low TSH which contributes. Can we carry on? I think we are still stuck.
Yeah, we should continue.
Yeah.
General physical examination. I have examined the patient under adequate light and proper exposure after taking verbal consent. Patient is conscious, cooperative, and well oriented to time, place, and person. Patient is fairly built and nourished. Body mass index is 16.42. Karnofsky score is 90. Triangular faces with loss of buccal fat, with prominent eyes, with staring look and thinning of hair is present. Patient temperature is normal by palpatory method. Pulse rate is 96 per minute with regular rhythm, regular rate and high volume. Sleeping pulse rate was 90 per minute. Blood pressure 130 by 80 millimeter of mercury. Fine tremors are present. Eye signs are present. I have explained them after the neck examination. No evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and any lower limb edema. Neck examination. On inspection, I have examined the patient in sitting position at the same level, approximately 8 into 5 centimeter butterfly shaped swelling in thyroid region at lower neck. Laterally, it extends from the lateral border of both the sternocleidomastoid muscle, superiorly up to thyroid cartilage and inferiorly just above the sternal notch. Overlying skin is normal. Swelling moves with deglutition and lower border of the thyroid is visible. There is no visible pulsation, scar, dilated veins, or any lymphadenopathy. Palpation. I have palpated thyroid swelling firstly while patient was in sitting position with slightly flexed neck while standing behind the patient, and then from the front at the same level. There is 8 into 5 centimeter swelling present in the thyroid region. Temperature is normal. There is no tenderness. Swelling has well-defined regular margin, soft consistency, smooth surface. Lateral border on both sides is below the sternocleidomastoid muscle. There is no thrill is present. Trachea is central in position. Carotid pulsation is palpable in normal position. There is no other palpable swelling in the neck. Percussion. There is resonant note present over the manubrium sterni. Auscultation. No bruise is heard over superior pole of the thyroid. Eye signs. There is no redness of eyes are present. Upper lid is retracted, and there is no wrinkling is present while patient is looking upwards. There is lower lid edema is also present. So there is no restriction of eye movement. On systemic examination, on per-abdomen, it is soft, non-tender. There is no organomegaly, normal peristalsis. Parectal examination is normal. Respiratory system, bilateral entry is normal. Cardiovascular system, normal. S1, S2 heart with no added sound. Summary. 31-year-old female patient having 8 into 5 centimeter butterfly shape, well-defined, soft thyroid swelling with regular margin with feature of hyperthyroidism and positive eye signs without any lymphadenopathy, voice change, dysphagia and dyspnea. My provisional diagnosis is Graves' disease, primary thyrotoxicosis.
Why did you put as features of hyper? You could have straight away told that if you want to say Graves' disease, you can always tell that. That's okay, summary. So thyrotoxicosis word is better. You understand?
Yes.
Primary thyrotoxicosis. That's what you want to say, correct? No?
Yes.
Why you put directly Graves' disease? What are the two major signs which suggest that it is a it is a Graves' disease?
Eye signs will be present. There will be tremors, tachycardia, thyroid swelling.
That all present, but eye sign is okay, and swelling of the swelling of the gland is also suggestive of Graves' disease. Okay.
Okay. Yeah. Rohit, I also agree with Dr. Rajagopal sir. I will say with features of thyrotoxicosis. Why? What is hyperthyroidism? What is thyrotoxicosis? You tell me now.
So, hyperthyroidism is increased T3, T4 secretion by the thyroid gland, and thyrotoxicosis is increased thyroid hormone along with the clinical features of hyperthyroidism.
No, you
No.
are half right. Hyperthyroidism means the thyroid gland is overworking. That means there is increase in the synthesis and secretion of the thyroid hormones. The gland is overworking. That is hyperthyroidism. Whereas thyrotoxicosis means it is just a clinical state in which the body or the tissues are exposed to inappropriately high levels of circulating thyroid hormones. It may be due to increased thyroid gland secretion, or it may be due to other causes as well. If you take overdose of thyroid tablets, what happens? You still can be toxic. Thyroiditis, you'll have a
Yeah.
transient toxicosis. So that is why you should put with features of thyrotoxicosis rather than with features
Yes.
of hyperthyroidism. If you put hyperthyroidism, first question I will ask, that means
Yes.
I will think you do not know the difference between hyperthyroidism and thyrotoxicosis. These are all basic. MBBS student can afford to make a mistake. At the postgraduate level, you can miss out on complicated things, big things. You should not make mistakes in your basics. Have I made myself clear?
Yes, sir.
Yeah.
Yes, sir. The same thing is, that's it, nothing but manifestations. You understand, no?
Yes, sir.
See, you have got so many organs getting affected here, correct? Not just increased levels. So manifestation, no? So that's
So
what.
which manifestations will be there in thyrotoxicosis, which do
So,
not explain hyperthyroidism?
so come on.
Ma'am, there will be eye signs is present. There is
Okay.
palpitation. There is perspiration. Patient is having diarrhea, weight loss, and there is also insomnia. Decreased sleep is there, and patient is having tachycardia and.
મેડમ તમે ટોક્સિકોસિસ પૂછ્યું ને
Yeah, so I was just hearing that he comes back to it.
રોહિત
See,
રોહિત
in
the first thing
thyrotoxic,
sorry yes ma'am please
continue, continue.
please
So
continue
there are few signs which explains about the which is seen in thyrotoxicosis. In patient is having hyperthyroidism with few signs which explains thyrotoxicosis. That is exophthalmos, as you say, eye signs. Then it is the pretibial myxedema
Yes, ma'am.
and acropathy, right?
Yes,
Okay, dermatopathy.
so
Okay.
the basic idea Rohit is to segregate the symptoms because of hyperfunctioning thyroid gland with those which you cannot explain by the hyperfunctioning,
Yes, sir.
right? So
Yes,
the
sir.
second question would come in line would be why these features are there, this exophthalmos and all.
Sir, due to the sorry.
Yes sir, you were saying something.
No. I just thought, are we going to proceed or we are going to discuss everything now itself? That's a simple query because we have not even gone to examination.
Yeah,
fully.
sir, you are absolutely right.
I
Rohit,
think
go
we
to the
should
first slide.
concentrate on the clinical findings now.
Yes, sir.
When
yes,
we
sir,
go
yes,
to
sir.
the management, we will trouble him even more. We will save him the embarrassment now.
Absolutely right, sir. Sir, please.
Don't
Shanoy,
use
sir.
triangular face and all those kind of words, I thought. I mean, opinion from my colleagues.
100%, sir.
I don't know what it is, sir.
I don't use this triangular, but definitely cushingoid is very well accepted. But
Yes.
triangle, I don't know.
Basically, I know what you want to convey. You want to
Yes.
convey that he has lost all. Probably just say loss of buccal fat. That is acceptable because
Yes.
triangular face it doesn't augur well. You should not physically maim the patient.
Yes, sir.
There are some
Secondly-
normal persons with a triangular face, so you don't. It need not be always abnormal for Rohit. So
Yes, sir.
not better not use that word.
Secondly, more important, it may land you in a huge valley where you may not be able to
Yeah.
come out again.
If I'm in a bad mood, what will happen? Tell me what are the types of triangle. I'll go off. I will triangulate.
Yes, sir.
That is why I say with the examiner, you should be. See, we are not only teaching you knowledge, we are teaching you how to approach the examiner. You should not give unnecessary diversions to the examiner. Examiner will be bored examining people, person after person. At some point in time, he will be a little irritable. If we use triangular, he will tangentially go off somewhere. You know.
Yes, sir.
Is he
These are the
anxious?
words I have told him so many times, but they don't improve.
Probably he's still interested in maths, I think.
Yeah.
Rohit, is he anxious? That's more important. Is he anxious? Is he sweating there? See,
Yes, sir.
I know that patient has been already treated. It's a treated case. Not that every physical sign you may get might have been altered. Those are taking more important here. You understand, no?
Yes, sir.
Because you are looking for a case of a primary thyrotoxicosis, basically, right?
Yes, sir.
So you have written the pulse rate, rhythm, volume, everything.
All that is there.
Any extra systoles that you have to find out, that is fine. Sleeping pulse rate you have quoted and pulse 96. Obviously, a question will be asked, how did you check the sleeping pulse rate?
So sleeping pulse rate, I have checked after patient was asleep in the non-REM stage of the sleep for the consecutive
Don't use
5 days.
non-REM. Did you use a EEG?
In the first 90 minutes of the sleep.
So what I'm trying to tell is, see again, there the question that comes is, it really should not be easily arrivable, because moment you put your pulse, he should not get up. So there is again the question will be asked, will you give phenobarbital, will you give diazepam? See, these are the issues will come.
Sir,
I will not use
told him
sleeping pulse
yesterday.
rate.
I
That
told
was-
him yesterday for PGs, just for information. I said, how did you take the sleeping pulse if you are examining patient? One.
Yes.
Second, why not resting pulse? Did I tell you, Rohit, to you about resting pulse?
Yes, sir.
So what is the difference between sleeping pulse and resting pulse?
So resting pulse after the.
But he will never hear to his PG teacher. He will hear to you all. I think so.
Sir. No,
Yes.
my moral of the story is simple. Just say pulse return enough. Let the examiner ask you question, no? Why I reserve it? If the time is there, so we'll proceed, no?
And sleeping pulse, see, with all, those were okay 50 years ago. When they didn't do free treaty for TSH and all those kind of things, when they used to diagnose everything clinically, not that we are not as good clinicians as clinicians 50 years ago, but we because they had to depend only on the clinical acumen. We have other laboratory aids. So I think sleeping pulse I would omit. Once again, you're fishing into troubled waters.
Exactly.
That is what I would say.
Exactly. In exam also, you are not taking sleeping pulse.
Yes,
right? Yes.
You can't take unless you sleep. I am sleeping. So we'll leave that. Delete. Forget and delete.
Yes, sir.
Yes. I also asked the student when he says sleeping pulse. Means I asked him for her, who is sleeping?
Yes, ma'am. You are saying something, Vijay, ma'am. What you are saying something?
Yes, you say you are given the pulse rate as 96 per minute. You want to say that the cardiovascular system is not that much affected compared to the other system, the nervous system, or is it only to say that it is a moderate and controlled toxicosis?
Or maybe the patient is on some medication.
Patient is on medication.
No, but patient has stopped the medication.
Stop medication. Yes.
Stop the medication.
She has stopped. In the history, if you remember, patient was on medication but not taking any medication for the last few months.
Sometimes it happens that patient continue with propranolol because it gives relief of the symptoms. So that also we have to ask.
That is one thing. And two, from what he is telling us, we are dealing with graves of primary thyrotoxicosis where the cardiovascular manifestations are less prominent. I won't say it is not there. 96 is still tachycardia. So we will accept his statement with regard to the pulse, I feel.
Sir, in your you said very good statement about the clinical. When we were studying, I don't know about it, we were having so much importance of the pulse rate.
Yes.
And we used to decide mild hyperthyroidism, moderate and severe pulse rate basic 90, 90 to 110, more than 110. And we have one good chart. I don't know anybody knows today's student, Wayne's index.
Vein syndrome. Veins index. Yes, sir.
Wayne's index.
Veins index.
So I don't know where. But those were the gone days. Now you have to improvise as the time goes.
So now you have pulse oximeter. Now hardly pulse oximeter tells you saturate every day. So we have to change with the times, but we should have the basic clinical acumen. Because if you don't have the basic clinical acumen, we won't know which instrument to use. That I mean, so we have to change with the times, but we should be grounded in our basics. We should never make fault in our basics. That's all.
But again, pulse oximeter will not give you the drop beats or
yes.
So we have to examine clinically for
No,
that.
yeah, I couldn't agree with you more, madam. I'm
Yeah.
just trying to say that how
Yeah.
times are changing.
Yeah.
Yeah, right.
Similarly, Rohit, you have added this word high volume. What is that?
What does it indicate? When you
So
mean
there
high
is
volume, what does it indicate?
there is a hyperdynamic circulation.
Yes, hypercirculatory state. Okay.
Yes, sir.
What are the other causes of hypercirculatory state?
Anemia, pregnancy.
When I was a student, high volume pulse also indicates aortic regurgitation.
Yes,
Remember, I know collapsing pulse and everything comes, but a high volume pulse, apart from hypercirculatory state, you should think in terms of aortic regurgitation.
yes, sir.
So the word high volume would be good, or bounding would be good, sir?
Both are equally good or equally bad, sir. Same.
That's what the moment he uses the word high volume, I expect you to mention collapsing pulse. Okay.
Yes. Aortic
This-
regurgitation should be at the
because-
back of your mind.
Yeah, because that's what
Yes, sir.
piston heart sounds and neurosis murmur. These are the two standard, signs of aortic regurgitation.
Yes.
Okay.
When you mention pulse, high volume pulse, the blood pressure is not showing hyperdynamic circulation.
Correct.
Blood pressure measurement is 130/80. What should be the blood pressure measurement in hyperdynamic circulation?
There will be systolic hypertension with wide pulse pressure.
Yeah. So it is not there in the patient.
Yes, ma'am.
Okay. Anybody else would like to ask, sir?
We'll go to
Or
the
madam?
proceed, sir. Proceed.
Okay, next slide. Let us go to them. Okay, so this is the another point I just wanted to, this is time word, because I usually prefer and I instructed him that eye signs should be mentioned last. So what is the take of examiners?
Sir, in this patient, particularly in this patient, because we are talking.
Obviously, yes.
So it will come as a separate local,
Yeah.
regional, like separate, apart from not in the general examination.
Exactly.
One word probably can be mentioned. Well, as I start seeing the patient, I am seeing a prominent eyes. Other signs I will describe later.
Yes, sir.
Rest of the signs I will describe later.
Which type of tremors is there? Which type of tremors is there?
Fine tremor.
Fine tremors. Which are the other tremors?
Coarse type of tremors, which can be due to Parkinsonism and cerebral disorder.
Okay. What type of coarse tremor do you get in Parkinsonism?
Sorry, sir. So in Parkinsonism, it will be resting tremors, pill rolling in Parkinsonism.
Pill rolling, resting. In cerebellar tremors?
It will be intentional tremor while patient start to work or doing something after that patient.
How would you measure fine tremors? How will you elicit?
So I will ask the patient to sit and bring both arms up and keep the hand extended.
Can you do it in front of camera if you don't mind? You are on camera.
Yes, sir. So I will ask the patient to keep his hand extended to see.
And the fingers should be separated.
Yes, and fingers should be separated.
Ideally, if really fine tremors, you put a piece of paper or something like that. It is easier to elicit fine tremors. Okay, it varies from examiner to examiner, but fine tremors sometimes you can put a piece of paper.
Yeah, yes, I agree, sir. And with one more caution, see that the fan
is not there. Switch off the fan.
Is not working.
Yeah.
This has happened to me only in my exam. That's why I'm always telling everybody. Okay. So what is the reason for tremor in a hyperthyroidism?
The reason for tremors, there is increased sympathetic activity, and the flexors and extensor of the hand are some of the fine muscles are separated, supplied by the sympathetic system, and there is a activity of the flexors of the hand is more as compared to the extensor, and they get fatigued easily. Due to that, there will be tremors.
I would just use the word increased neuronal excitability and leave it to that.
Yeah. Let the examiner ask details. right?
Because by doing this, you are digging your own grave, I think.
Why
When you say
separate your
muscle
finger?
particulability, examiner will ask you about the small muscles of the hands. So
Exactly.
don't
Yes.
say this, right? Okay.
Why you spread your fingers while looking for a tremor? You know that is just for the PG student. The point here is that the small muscles of the hand has a very rich sympathetic supply, the lumbricals and introci. And in a presence of hyperthyroidism, they get fatigued easily, right?
Yes.
And because of that, when you stretch your finger, they comes in action and gets fatigued easily, which lead to development of tremor. And the what you were saying, flexor and extensor, is definitely a sir said digging your grave. Leave it to that, right? Again,
Yes.
that will be that you put your palm upward or the dorsum upward. Those are the questions that will be asked. But keep it like that. It is related to sympathetic overactivity, neuroexcitability, as sir has said.
And
Okay, sir.
the other reason is also common sense. When you spread, one lumbrical doesn't, one finger doesn't support. When you do this, one finger supports the other, so you cannot find subtle tremor. That's why you spread your fingers.
Yes.
What is apathic thyrotoxicosis? When we
Sorry.
are talking about sympathetic overactivity,
Yes, ma'am.
what is apathic thyrotoxicosis?
Ma'am, apathic thyrotoxicosis, the signs and symptoms of the thyrotoxicosis will not be very well present in the patient. It commonly occurs in the old patient.
Old age, yes. Yeah.
T3, T4 will be raised, but symptoms will not be that apparent.
Basically, there's apathy. There's thyrotoxicosis, but there's apathy. That is a very, very simple way to remember.
Yes,
Good
sir.
morning, Dr. Ritesh Agarwal.
Yes, sir. Very good morning.
Thanks for joining.
Welcome, sir. Welcome, and my pleasure too for inviting me.
Please chip in whenever you feel fine.
Yeah, sure.
What is the cause of retraction of the eyelid, Rohit?
So there is a contraction of the molar muscle in the levator palpebrae superioris due to the sympathetic overactivity.
The levator, what is it? What did you tell? Levator palpebrae muscle is supplied by what?
Sir, levator
Muller
palpebrae.
muscle. What did you tell?
Sir,
Yes.
it is
Mueller's
due to the
muscle, he
contraction
said.
of Mueller's muscles.
Sympathetic component
Yes.
of the levator palm, you are talking about that, which is inserted to the upper tarsal plate. Okay.
Yes.
So that is the sympathetic part. That's why the sympathetic activity was more.
Yes.
Carry on.
Yeah, next. I think it's both lobes enlarged, 8/5, whatever you have written, that a temperature normal is not required in this, we are not looking as a thyroid as a, you may think it's a vascular thyroid, etc., but it's not local raise of temperature like any other neck swelling or something. Increased vascularity, yes, rarely probably can give rise. That's what you want to say. 8/5 is, I understand, as horizontal and vertical, correct?
Yes, sir.
So you mean to say this 8 means both lobes are enlarged? Is
So
this
is it individual lobe is 8/5 or total?
Sir, totals.
Any bruise that you heard that auscultation time?
No, sir.
Where will you look for the bruvi?
Sir, on the superior part
Sorry,
of the,
not look. Where will you hear the bruvi?
Yes.
I should frame my question properly.
sir, on the
We understand, sir. No problem.
superior pole of the lateral lobe.
Why?
Because superior thyroid artery, there will be increased circulation and it is more superficial, and it is a
Yes.
direct from external carotid artery.
Yes, it's the direct and the first branch of the external carotid artery, and so any increased blood supply will will lead to the audible bruit over there. Okay.
Yes.
What is Barry's test in this patient?
In case of malignancy, there will be involvement of the carotid sheath and carotid pulsation will be absent.
Better use the word engulfment of the carotid sheath rather than involvement. Well, I think you told involvement, correct? Huh?
Yes.
So why that word? What's the importance of that? What madam asked that question? Barry's sign, whatever. So
In case
carotid may not be palpable, but what else can be palpable so that you know the lumen is not compromised?
so it will be displaced laterally. In case
Sorry?
in case of large thyroid swelling, the carotid pulsation will be displaced laterally and superiorly.
So in a benign swelling, it is displaced, and in a malignant swelling, it is engulfed, right?
Yes, ma'am.
Yes.
So in malignant swelling, you may not be able to feel the carotid pulse. In a in a large benign swelling, because the carotid is displaced, you will feel it, but not in the normal position. Maybe a bit lateral. That is what all of us are trying to tell you. Okay.
Yes, sir.
Is malignancy common with thyrotoxicosis?
No, ma'am, it is not common. It can be seen up to 3 to 4% cases of thyrotoxicosis.
Urvi, we have already discussed that part, I think, before you joined.
Okay, sure.
Capillary
Yeah,
CA and
again,
vision is also
one
discussed.
more thing.
Thank you. Yeah.
Here
Yes,
you
Vivek.
said the lateral border on both sides is below the sternocleidomastoid. What is that? What does that mean?
Posterior. Posterior, not below men.
Yeah, you should
Behind. It should be behind.
Behind. Yes.
That the swelling is between the investing layer of deep cervical fascia and the
I don't think I will mention that statement. It will lead you to unnecessary trouble.
Yeah.
He's very,
better
very
avoid.
fond of trouble. He's
Yes,
very
I know. He likes to fish in troubled waters.
Yeah,
Fishy
I
character.
think. Yeah. He is from Mandi,
Ah.
Himachal.
Ah. Because I think always keep it simple. Remember, don't tell anything which will lead the examiner to ask you unnecessary questions. You see, examiner, as I told you, practically is board examining the entire day. So the next question is from what question or what answer you tell. The examiner doesn't prepare and come. Even if he prepares and comes, first few candidates, he would have exhausted his questions. So later on, he will feel bored to ask the same question. So what question or what answer you give, he'll pick up from there. You know?
Yes, sir.
So exactly, how many times did you hear this talk? That examiner is exhausted. 100 times I have told them in round. That but he is trained by Kangna Ranawat, MP from Mandi. So she is also very fond of picking the troubles. Anyway, okay. Please, sir, anything you would like to ask for this?
What does that resonant note in percussion indicate? What are you trying to tell us?
So there is no retrosternal goiter or there is no any mediastinal lymphadenopathy.
Why do you look for mediastinal lymphadenopathy here? Just say no retrosternal goiter, because I don't think you should unnecessarily commit yourself. Probably no retrosternal extension, but highly unlikely because you said you can see the lower border, you can feel the lower border. Yeah, but as a matter of completion, you're saying, fair enough.
But can there be a retrosternal goiter even if you can feel the lower border?
Yes. Yes. Clinically, sometimes it may not be all that accurate. Sometimes a little bit of a posterior extension, you will not be able to perceive the retrosternal extension.
Exactly, because there can be it is by a small stalk that it might be going. We do come across occasionally, but fair enough. He has written fine. Yeah.
So what is there to say that it is only a thyroid swelling?
Yes, ma'am.
That is a very good question. You told all that. Why do you say it's a thyroid swelling? That's a superb question. Why?
So swelling is present in the thyroid region.
Okay.
And it moves with the moves.
You didn't tell us that. Did he tell us that it moves with deglutition? I may have not heard.
Yes, he told in the history, I think.
Oh, I'm sorry. Pardon me. Okay.
Inside. inspection.
Shape.
In palpation also, you should have told, Yeah. Anyway,
Yeah, the movement with deglutition is the normal even for the UGs. We expect that, isn't it?
Yes, ma'am.
you should emphasize on that, because that is the cardinal clinical sign which says that this is something enclosed in the pretracheal fascia and more likely to be the thyroid, Okay.
Yes, sir.
So in both inspection and palpation, both.
You have not mentioned in the palpation. I'm sorry I missed it in your inspectory finding, but you should mention and confirm in palpation, definitely.
Yes, sir.
So as you said, it is a butterfly-shaped swelling. Why it maintains its butterfly shape even if it enlarges too much? Because most of the swellings becomes rounded, irregular like this. But thyroid swelling always maintains as far as possible butterfly shape. What is the reason?
Sorry, ma'am. I don't know.
So it is encased into the cervical fascia and it is attached, that fascia is attached with the oblique line of thyroid cartilage. So it do not progress much upwards. It enlarges laterally as well as downwards. And so it maintains its butterfly shape, right?
Yes,
Okay.
We will
Let
not
us
bore you
move to
with
the
the
investigation part, sir.
Yeah, we will not bore you with the other questions. I'm sure you know why it moves with deglutition. What
Yeah.
are the other structures which move with deglutition apart from the thyroid? We presume and assume that you know, and we'll carry on.
Exactly. Yes, sir. There is only one question because which the students are very fond of, and I also corrected him yesterday. So I wanted other students to know. They are very used to it that they write down in one sentence, this swelling moves with deglutition and does not move with protrusion of tongue.
I don't think you should commit that. I would just say it moves
Exactly.
with deglutition. During the presentation, you can say it doesn't move with protrusion, or if the examiner asks, you should, but it varies.
If there is a multinodular goiter, like as he rightly put it, occupying both lobes and the entire
Exactly.
isthmus, we don't expect the usually
Yes.
students.
That's what I
There
told.
is a solitary nodule. There's a
Cystic in
solitary.
nature.
Yeah.
So yes.
So
that
for
is
the
the time.
students, what the sir has said, if you find solitary nodule, you are entitled to mention about movement with protrusion of tongue. In a bilateral swelling, you shouldn't mention movement with protrusion of tongue. Stick to movement with deglutition only.
Yes, sir.
Okay,
Yes,
let's carry on.
Yeah. Yeah. There is one more thing, sir. Yes, this is the one I actually told him to keep. About eye signs, there is lot of confusion in students. So, Rohit, what is difference between exophthalmos and eye signs?
Exophthalmos, there is due to the retrobulbar edema and deposition of fat and hyaluronic acid, there is
I am not asking the reason for exophthalmos. I am asking you what is difference between eye signs and exophthalmos, or are they the same thing?
Sir, exophthalmos, it occurs in the primary thyrotoxicosis, and eye signs, it can be present in both primary and secondary thyrotoxicosis.
I beg to differ.
Yeah.
Whenever you think in terms of eye signs, you're thinking in terms of primary thyrotoxicosis. My colleagues.
So what I understand,
sir.
Yes, sir. Please, sorry, sir. Please.
As first part, sir, fully agreed with this, Vittal sir. That is, whenever we talk about thyrotoxicosis, eye signs, means we generally refer to primary thyrotoxicosis.
Primary. At least for the exam.
Yes.
Maybe subtle. Life is not 100% in the, I can tell you. Nothing is clearly demarcated in life. Patient should have like this. We are telling for the exam. As far as exam is concerned, eye signs means primary thyrotoxicosis.
Subtle eye signs may be present very early in case of secondary, but never progressive exophthalmos leading to corneal ulcer, blindness.
All that will never occur.
Never,
ever.
Yes.
Okay. So what I take I would like slightly differ. The
Yes, sir.
eye signs include exophthalmos with signs of sympathetic overactivity. That's what I understood. So a lead leg and lead spasm can be occasionally present in secondary hyperthyroidism. Otherwise, eye signs means exophthalmos plus signs of sympathetic overactivity. Sir.
First,
Yes, sir.
Point taken, sir. For the exam, we will say eye signs means primary, sir.
Yeah, yes, that's what, because there is always a confusion with the students, right? But you should remember the eye sign comprises of exophthalmos plus signs because of sympathetic overactivity, which accentuate the exophthalmos because the patient has a retrobulbar deposition, eyeballs protrude out, and there is a lid leg and lid spasm, which leads it look more frightening, what is classically known as a Dahl-Rimpel sign. Please.
Rohit, one question to you. How do you differentiate this exophthalmos from, why not proptosis?
So,
Proptosis. There
So-
is some small brain tumor is causing you forward protrusion of the eyeball.
G4 test, there is a
What do you do in that?
there is a difficulty in eversion of the upper eyelid due to
Good.
the edema.
So upper eyelid cannot be everted. Correct.
Yes, sir.
Good point.
Remember in exophthalmos in due to thyroid, it is usually bilateral, and it can be symmetrical or asymmetrical. Remember, rarely, this is just for your knowledge, rarely it can also be unilateral, but classically it is bilateral, maybe symmetrical or asymmetrical. Remember that.
Okay. Why you cannot evert upper eyelid in exophthalmos?
Yes.
So there is a lid edema is there, and there is also spasm of the molar muscle also.
Spasm.
Spasm is more correct. Right.
Edema may or may not be. It's again sympathetic overactivity, which is present only in a thyrotoxicosis, which will not be present in proptosis. Okay.
Generally, one easy way of understanding, it's not complete. If you look at the eye signs of due to in Graves, one, it is due to the problems with the ocular surface. So because of the ocular, because of exposure keratitis, ocular surface, you may have grittiness, lacrimation, photophobia. That is due to the ocular surface. Then next, due to the muscle involvement, the extraocular muscle. So because of muscle involvement, you may have diplopia, you may have strabismus or pain on movement. Third is the optic nerve involvement. Then you will have decrease in visual acuity and color perception all. So I just want you to classify so that you can easily understand rather than rattle everything together. I hope my colleagues agree.
Yes.
Yes, sir. Absolutely
Yes.
right.
Carry on. And remember, you can read from your book. Certain examiners will be very keen to ask you the proper names of all this. It varies from examiner to examiner. I will not worry about the names, but there may be some colleagues who will want to know what is Mobius sign, what is von Graff sign, what is Dalrymple sign, and all. So read up from the books.
Sir, it's a very coincident. Yesterday only I removed from this presentation all name of a sign.
Sir, you should not call me for the, you are telling everything what I say. So I don't need to come. You are more than enough, sir.
Neither point, because this is the one more point I wanted to discuss. So name, if you know, it is good enough, but you should know the mechanism. That is more important.
Exactly, sir. You should know what it is. Name may or may not. It all depends upon the examiner.
Yeah.
You know. Because
okay,
sometimes,
sir, your take.
Yes, sir. Definitely.
Definitely.
Because what happens is they will convert the Warren into Geoffrey to Darling, all that.
yeah, I will not penalize the candidate as long as he knows that he is not absence of wrinkling, absence of convergence. That is important. Not when you mix up Dalrymple with Geoffrey sign. That is memory. I think that is not worth it.
Did you look for proximal myopathy, Rohit? In one of the important thing happens. Did you mention anywhere
No,
apart
sir,
from the eye signs, Rohit?
I have not mentioned, sir.
You have to mention what is that.
So
what is that, dude?
So in case of thyrotoxicosis, there will be proximal myopathy,
So
weakness
what is
of.
the patient complains you? He doesn't tell I have got proximal myopathy. He will tell one complaint.
Sir, patient will complain difficulty to stand up when patient is seated.
Getting up. Yes. So
And-
you have to specifically ask for it. Like those things are very specific in primary. They are never,
For
never,
upper limb, for upper
never,
limb, as you have said, sitting to standing, it is for upper limb. What will be the complaint?
combing of hair, ma'am.
Combing of hair.
Yeah, shoulder movements mainly, shoulder
Yeah.
and elbow.
they are,
Combing
these
hair,
things are
lifting the hand.
never seen in a secondary. You understand?
Yes.
Never seen. Proximal myopathy, all this, that pretibial myxedema, progressive eye signs to going to blindness. These are all, few very specific entities. Okay.
Few
You have to mention.
few words about pretibial myxedema. I'm sure all of you know it's a misnomer.
Yes.
Very rarely seen it's
Yes,
difficult to perceive in our colored races. It's probably easier in the Caucasians, number one. It's a very rare sign or whatever. When you have pretibial myxedema, you'll always have eye sign. Remember that.
Yes.
And what is it? It is nothing but a deposition of your hyaluronic acid and chondroitin in which layer? Dermis. It's usually pink or purplish patches of non-pitting edema, usually seen in the shin region. Nothing is required if you want topical steroids. Rare sign, but usually associated with eye signs. Just a short synopsis of pretibial myxedema.
Same thing goes for thyroid ectropathy.
That is even more rare. Clubbing with soft tissue swelling of the
exactly.
fingers and, So these
It is
are the four
extremely rare.
classical things of Graves. Diffuse goiter, diffuse goiter, eye signs, pretrivial myxedema, and acropathy are the complete four subsets of primary thyrotoxicosis or Graves' disease, of which the goiter and eye signs are the common. The last two are very uncommon. Even your eye signs is present only in 25 to 30% of primary toxic goiter.
Yes, sir.
Ritesh bhai, anything from your side?
No, sir.
Thank you, sir.
Okay, sir.
Continue.
How will you
Sir,
investigate this patient?
Sir, okay. So we forget the how do you do the eye signs? We'll just we can read it from the books. That is fine. Okay.
G capital, G capital. Okay.
Yes, sir.
My friend. Yes.
Okay. So, ma'am's question: how will you investigate?
I would like, first of all, I would like to do the thyroid profile, free T3, free T4, and thyroid stimulating hormone. And I would also like to do the thyroid receptor antibody test, thyroid stimulating antibodies for the antibody status, and anti-thyroglobulin antibody and anti-thyroid peroxidase antibodies also.
Can I interrupt you there?
Yes, sir. Sir, please.
With regard to the antibodies, when you are doing your, first of all, you should be more specific. It is called TSH receptor antibody or thyrotropin receptor antibody. It's called TRAB. Okay.
Yes, sir.
When you're doing that, I don't think you need to do your anti-thyroglobulin antibodies and anti-peroxidase antibodies, because if you don't have facilities for this may just be a rough guide. Because if you do your TRAB, it is 96 to 98% sensitive for Graves and nearly 99% specific for Graves. So if you're doing this, I don't think you need to do that, because it's very highly unlikely where the TRAB is going to be negative and others positive and it being Graves. If it is Graves, invariably your TRAB will be positive.
Yes, sir.
Rohit, I think you can stop slide sharing and you can start in a gallery mode only.
Yes.
So, sir, is it always free T3, T4?
You can also just say whatever sir said, just like to remember, otherwise you'll forget, just like we say, clinical assessment, you know that what happens in a thyroid, we always expect a triple assessment. Na? So you
Yes,
can add a word here, quadruple, so that you don't forget the 4 components of that. Clinical examination, but importantly, thyrotoxicosis, you don't do a FNAC here, but just to add on, ventilator goiter, yes. Here you do a clinical assessment is done, then functional status, then the cause of the functional status, followed by, of course, imaging or scans.
In fact, that is what I say for goiters.
Yes.
You, apart from clinical, you need investigation for anatomical diagnosis, physiological diagnosis,
Yes.
and pathological diagnosis.
Yes.
For anatomy, ultrasound neck. In this case, okay, you need to do you need to do other things as well. For physiological status, the basic thing is a thyroid function test. Pathological status,
Yes.
FNAC, it may or may not be inappropriate in this case, but generally in goiters, this would be the bare minimum. Carry on.
so I would also like to do ultrasonography of neck to look for any suspicious nodule in the thyroid gland.
Now talk about your patient. Now, why brought out suspicious
Yeah.
nodules? No.
First, you say you've done a free T3, T4, TSH, you said.
Yes, sir.
Okay. What were the findings? Tell us.
Sir, free T3 and T4 was raised, and TSH value was 0.0001 micro international unit per liter.
Okay. When the TSH is low, is there any other test which you'll do? What is are there any other investigation you'll think in terms of? Okay, let me put it this way. Would you think in terms of scan, functional scan? Iodine scan or a technetium scan, do you think it may be prudent to do? Do you think it can be done? Should be done?
In this patient, sir, there is no any there is no any swelling. There is no any nodule is present on the ultrasonography, and so I would and on ultrasonography there is a diffuse enlargement of the thyroid gland without any nodules. So I would not like to go for it. Sir.
I agree with you if it's very classical with eye signs, with a goiter, maybe. But if there's any doubt, I would always do some sort of a functional scan, like a easily available one is a technetium scan. Why would I do it? What will it tell me?
So it will tell the functional status of the nodule. It is functional or non-functional.
First, you will say about the whole thyroid, uptake of the thyroid.
Exactly. Okay. Whether this is, first of all, whether this is hyperthyroidism or not, will tell you. Because sometimes you are in a transient thyrotoxicosis due to thyroiditis also, you can have similar features, but not eye signs. So if you want to differentiate between thyroiditis and actually hyperthyroidism, you will have to do a functional scan. In this case, it is very classical. You may not do it. And if I am the examiner, if you say you don't require in this case, I will agree. But any doubt, I think that should be done. Okay.
Yes, sir. Yes, sir.
What else will be seen in thyroid scan?
We will see the uptake and functional status of the.
That is uptake.
And
the functional status is only uptake.
And if there is any suspicious nodule is there, which is hyperfunctioning or with increased uptake, is there or not?
Okay.
Whether there is any toxic nodule, whether there is any cold nodule, these are the things. Suspicious nodule will not be seen in a functional scan. It will be seen in the ultrasound. Yes, you said you did an ultrasound. Why did you do an ultrasound? What were the findings?
So there was diffuse enlargement of the thyroid gland without any. There was no nodules present in the thyroid gland with increased vascularity, suggestive of possibility of the Graves' disease in view of symptoms.
Yeah, so the ultrasound, even in Graves' disease, you will do ultrasound. One, you can find out the enlargement. 2, yes, a Doppler will show increased vascularity, which adds to your findings of Graves' disease. 3, you'll pick up suspicious nodules. This is very important. Sometimes, as I told you, toxic goiter can be associated with malignancy. If a suspicious nodule, I know there's 2 schools of thought. When after being clinically euthyroid, you can definitely do an FNAC to rule out any malignancy. Okay?
Yes, sir.
Involvement of the carotid and retrosternal extension. These two can be also seen, right? Okay.
Yes, ma'am.
Why did sir say that return to euthyroid and followed by FNAC? Why not now?
So,
Do you get me, Rohit?
yes, sir. Yes, sir. So currently patient is in thyrotoxic state. There is increased vascularity. There is risk of hemorrhage and thyroid storm.
I will not go overboard with thyroid storm. Basically, hypervascular gland, you just want to minimize the chance of bleeding.
Yes.
See, thyroid and for Rohit, thyroid and breast, so thyroid is highly vascular organ, and sudden hemorrhage can also give rise to tracheal compression. You know that, no?
Yes,
Just like how a nodule, one of the complication of a nodule is a hemorrhage formation. And
Yes,
it's a closed space, deep to the pretracheal fascia. So this is very important. So that is one problem. Yes.
Sir, my question to Professor Vittal is, how do you know it's a suspicious nodule, sir?
So that our sonologists will tell you, sir, you know, there are so many aspects, the thyroid staging is there, thyroid, based on composition, echogenicity, margin, shape, echogenic foci. Based on that, you have thyroid staging is there. So, 1 is benign, 2 is not suspicious, 3 is mildly
Sir, I think that should be the question for Rohit. I'm sorry.
I already blurted the answer out, sir. I apologize.
No, sir. No,
No, sir asked you, but I think that question should be for Rohit. He should know.
No problem. Sir,
No, that is the way you do it, sir. The American College of Radiology, that's a widely followed one. The American College of Radiologists have standardized ultrasonic reporting, just like how you have for BIRADS for breast in mammography, you have thyroid for ultrasound. So based on these features, they are they are graded from, I told you so. Any suspicious nodule, better to FNAC. The reason is, if you are thinking in terms of malignancy in a toxic goiter, you will not give radiation as the mode of treatment. You will definitely advocate surgery, sir. That is why nowadays it is prudent to do an ultrasound scan. Number 1, to see the enlargement. Number 2, of course, in Graves' disease, increased vascularity. Number 3, to rule out suspicious nodules. But he has very clearly pointed out diffuse enlargement, no nodules. That's all.
No nodules, sir. Yeah. Sir, if there is a suspicious nodule, using high resolution ultrasound, can we do an FNAC from the nodule?
Yes, sir. That is what I'm saying you should do, sir. But when it's very toxic, you should be very careful. Better to just wait. Nothing will happen in a couple of weeks' time, even if it's malignant. Better to make him euthyroid and do would be the message I want to give, at least for the examination candidates.
Yes, please. Rohit, note it down.
Yes, sir.
Okay, sir. Thank you.
Now you have done USG and it is showing Graves' disease. Now what will you do?
I would like to start the patient on tablet carbimazole, 20 milligram 3 times per day, along with the propranolol.
You can say medical line of management, sir.
Yes, sir. To prepare the to make the patient
medical line of management to bring down the patient to euthyroid
state before planning for surgery.
How will you follow up this patient after starting medical treatment?
What are the drugs you give and where do they act?
So carbimazole, it acts on the thyroid peroxidase hormone, prevent the
centrally acting antithyroid.
yes, and propanolol will prevent the peripheral conversion of the T4 to T3, and it also control the increased sympathetic activity.
So how do you give the dose?
Sir,
Start
propanolol.
with?
Sir, I will start with the 40 milligram.
40 milligrams straight away.
Sir,
No, neomercosol, how do you start with?
sir, 10 milligram 3 times per day.
Sir, yes, sir, for you. That
Yes,
routinely what we do is we go for a maximum dose and then reduce the dose. Vithal, sir?
Depending on the thyroid value, you start the dose.
The good thing is to see the level of the thyroid.
Yeah.
See the level of the thyroid hormones. There are various ways, but the general principle, you start with a high dose and bring it down. But how high? It's a rough guide. 1 to 1.5 times the level is high. Usually start on maybe around 10, 10 milligram, 10 to 20. If it's 1.5 to 2, then maybe 20 to 30. Then if it's probably more than 2 times, higher dose, a rough working guide based on your T3, T4, you titrate the dose, but usually you give it at a higher dose, Normally in US, the methimazole was available. In India, carbimazole was available. Nowadays, even methimazole is available because your carbimazole, when you give, is converted into methimazole in the body. You can give either carbimazole or methimazole. Remember, 10 milligram of carbimazole is get converted to 6 milligram of methimazole. Okay, so nowadays even methimazole is available.
So
that is remember.
Rohit, patient comes to you after some days with some trouble.
Yes, sir.
What trouble and what do you suspect? The general question. Patient, you start them as a new patient. You start them on the carbimazole or methimazole.
Yes, sir.
Patient comes to you after 1 week or 10 days, depending on the patient's immunity.
Yes, sir.
What do you think this symptom and what do you suspect?
So it could be due to the allergic reaction to the carbimazole.
And what will be the first symptom of carbimazole?
So fever, arthralgia.
No, it is sore throat.
Yes.
Sore throat.
Due to what?
Am I correct, sir?
Due to agranulocytosis, carbimazole it leads to
reversible
agranulocytosis.
Right. What do you do if the patient comes to you with sore throat? What do you do?
So first of all, sir, I would like to do the complete blood count and the peripheral smear.
Stop the drug first.
Yes. And I would also start patient on antibiotics.
You
also.
do a peripheral smear.
Yes.
Then how do you follow?
So, if patient is presenting with fever and sore throat, I will start the patient on antibiotic, and I will follow up the patient with the complete blood count to see any improvement in the complete in the blood count, sir.
What will you do about the thyrotoxicosis?
Yes, ma'am.
You are going to stop the neomercazole because of the agranulocytosis. Then what will you do? How will you manage the thyrotoxicosis?
I can start the patient on propylthiouracil alternate tablet. Yes.
What is the side effect of propylthiouracil?
Propylthiouracil it lead to dose independent hepatotoxicity.
Yeah, acute fulminant hepatic failure can be there. So,
Vital, sir, you are saying something, sir.
No. I just wanted to summarize for the
Please,
benefit
sir.
of Rohit and myself. If you
Please,
take
sir.
the adverse drug reactions of carbimazole or whatever PTU, remember, first and foremost, both of them can cause agranulocytosis. As sir and madam said, you not only do a blood test, you should say you will do a total count and a differential count. That is important. Just not, you should also do a total and a differential count. And as soon as you have fever or sore throat, we should stop. If there is no agranulocytosis, then it's due to other cause, you can continue. So just because you have fever and sore throat, you stop, do the test. If the test doesn't show a drop in granulocytes, you continue, it's due to other cause. But if it's due to agranulocytosis, then as madam said, you can use PTU. But remember, PTU can cause acute fulminant necrosis, number one. Number two, usually it occurs within the first 4 months. So if it doesn't occur in the first 3 to 4 months, it is generally unlikely to occur.
Yes, sir.
Carbimazole also is hepatotoxic, but it is mainly cholestatic in nature. It doesn't cause fulminant necrosis, it causes cholestasis. These are things you should remember. And PTU comes in 50 milligram tablets and 100 milligram tablets, you know.
Yes,
And once again, it should be given in divided dose. The advantage of PTU is it also, in addition to decreasing the thyroid hormone levels, it inhibits the conversion of T4 to T3 as well.
yes,
The advantage of carbimazole is, in addition to decreasing the thyroid hormone synthesis, it is more potent than PTU. It is also believed to have immunomodulating properties. What do I mean? We know Graves' disease is a autoimmune disease. It is also believed to have some immunomodulating properties. That is why when you are using anti-thyroid drugs, your first drug of choice is carbimazole or methimazole. Okay, they
yes,
belong to the categories of imidazoles. They are the first line of drugs. Your second line of drugs is your PTU. Okay, PTU is a second line of drugs when you cannot use this. The main advantage of PTU, where it is used, I thought we'll discuss it later, but because we are discussing drugs, I'm telling now, it is useful in the first trimester of pregnancy, because your carbimazole and methimazole is teratogenic. It cannot be given in the first trimester of pregnancy. What can it cause? It can cause a skin condition called aplasia cutis, and it can cause esophageal atresia in the newborn. So in a pregnant patient who needs anti-thyroid drugs, in the first trimester, the drug of choice is PTU. And even when you give the PTU, you should give the lowest possible dose. Once the second trimester comes, from PTU, you switch over to your carbimazole or methimazole. That is the treatment of toxicity in pregnancy. In pregnancy, radioiodine is a definite no. You will not give it in first, second, or third trimester. So you forget about radioiodine in pregnancy. Anti-thyroid drugs in pregnancy, first trimester PTU, second and third trimester your imidazoles. Surgery, if you want to do, you will not do in first trimester. Why? You will cause abortion. You will not do in the third trimester. If at all you want to do surgery, you do it in the second trimester. This, in a nutshell, is the management of toxicity in pregnancy. I'm sorry, because of lack of time, I've just introduced these concepts when we are discussing anti-thyroid drugs. I hope Madam Urvi agrees with me.
Yeah,
Please
totally agree, sir.
to correct me.
No, totally agree, sir.
Okay, furthermore for Rohit.
Okay, management of toxicity. You said you will give your
Sorry,
anti-thyroid drugs.
sir. I took time in unmuted. So did we discuss can the antithyroid drug itself cure the Graves' disease?
Okay, sir. You want me to
Wait,
answer or Rohit
let
to
him
answer?
Rohit.
Rohit. Okay, sorry.
Yes, sir. In some sir, approximately 50% of cases after giving antithyroid drugs to 12 to 18 months.
Rohit, the answer is, the question is clear. Can antithyroid drugs cure the disease itself?
No,
The
sir.
gland is enlarged, you said.
Yes, no, sir. It cannot.
So answer to Dr. Modi, sir.
Yeah. So what actually the thing is that antithyroid on its own never cures the thyrotoxicity. It controls the thyrotoxicosis.
That's the exact word.
Right?
That's the exact word. It only controls.
Yeah, exactly.
Your aim is, when you control, you hope the autoimmune process remits. So you are basically giving symptomatic treatment. What happens, as I told you, coming back to what I told you, your carbimazole and methimazole have immunomodulating properties. So when you give that, that itself might help. Two, when you make the patient euthyroid, that itself may sometimes help in the dysregulation to cure itself. Basically, what happens is the autoimmune process, hopefully you hope it remits when you make them clinical euthyroid. So it doesn't cure. That is why traditionally they allow 12 to 18 months. If it's not going to remit within 12 to 18 months, at least for your exams you use 12 to 18 months, it's not going to remit.
Yeah. So that is what you should. It is not a treating, it is only controlling it, but hoping the self-remission, which occur 15 to 20% of the cases.
In Graves, not in secondary thyrotoxicosis, it's only in primary thyrotoxicosis.
Yes, exactly. So that is the basic difference. In a primary, you should continue antithyroid drug for 12 to 18 months, hoping that it may. If it doesn't, in secondary, there is nothing like that. So the mechanism is totally different. Urvi ma'am?
In stages of MNG, if you read in Bailey Law, is that the first is the diffuse enlargement of the goiter. And he has mentioned clearly, this is the only stage in the multinodal goiter which can be reversed by medication alone. But people don't come to you at that stage. The first stage is the only stage which can be reversed by medication.
Yes.
Go and see, please, Rohit.
Yes, sir.
The stages of MNG.
So when we are talking about the remittance of Graves' disease, I want to ask that what is the indication for surgery in a Graves' disease?
Ma'am, if there is a diffuse thyroid swelling is present, and patient is in reproductive age group, if any suspicious nodule is present, and in a young patient, where radioiodine is relatively contraindicated, and there is no response to treatment, medical management. And if pressure symptoms are present.
See, what? You are right, but not right. That's what I'll tell you. That is, you vaguely know. First of all, the treatment modality varies from where you go. You know, in UK, it's different. US is different. Indian subcontinent is different. Finally, here, to whom you go. If you go to madam, she will start first on antithyroid drugs and probably radioactive iodine. If you come to me, probably make them euthyroid, large goiter, operate. It varies. But generally, if you want to know what is there are indication for surgery, remember, large goiters, number one. Two, retrosternal goiters. Number two. Three, suspicious nodules. You should. Number four, whenever you said, you know, young people, that's very vague. I consider myself young. Okay. So
You are young,
I'm young,
sir.
I know it.
You are
So
still young.
generally, less than 5 years, you will not you will not venture into radioiodine. Less than 5 years, better surgery. Then there are other reasons as well. I told you about malignancy, large goiters. Patient wants to conceive, within next 6 to 12 months. You can't give radioactive iodine. Then exophthalmos is there. Radioiodine is a relative contraindication. It is not an absolute contraindication, because when you give radioactive iodine to a patient with exophthalmos, it can worsen. So these are the criteria.
Sir, let me ask him this question. Why it is relative contraindication? You are answering all the questions. He is very happy. Yes, Rohit. Let him say, I don't know.
Sir, because radioiodine ablation is associated with the worsening of the eye signs.
Why?
Uh,
Why this happens?
Because thyroid receptor antibodies will act more on the retroorbital area as compared to the thyroid cell.
Yes, sir. Did he answer or not?
He's answered. He's asked me. He knows the answer, but he's scared of us. I think he's not elaborating. Yes, I think it'll worsen because of your antigen antibody reaction. The entire process will be exacerbated. Although my medical colleagues or my nuclear medical colleagues will say you can add steroids and give. That is why it says relative contraindication, not an absolute contraindication. Same reason, retrosternal goiter, it's a relative contraindication because it might swell up and it may cause compressive features. So remember, large goiter, retrosternal goiter, suspicious nodules, definitely you will. Then a pregnant lady, those who want to conceive within the next 6 months to 1 year, yes. Those who have young children less than 5, definitely yes. After that 10 years, you can give radioactive iodine, but generally no. Okay.
Yes,
And in
Other way
our
around.
country,
When
in
will you
our
give
country,
radioiodine? What is the good indication for radioiodine?
Sir, if there is a hyperfunctioning nodule is present, autonomous nodule is present, or there is a recurrence after the surgery is there, and sir, in case of ectopic thyroid tissue in retrosternal goiter.
Retrosternal goiter, just now I said you will not give. That means you have not even listened to what I said. Retrosternal is a relative contraindication. It's a closed space.
Yes.
If the goiter enlarges, it can cause compressive features. Similarly, orbit is a closed space. That is why you don't want to give.
So,
Sir, just for a lighter side, he is with me since 3 years. He never listened to me even once. So how can he listen to you?
It's, as long as there's life, there's hope, sir.
Absolutely right.
See, I will tell you, because lack of time, classical indication of radioactive iodine, small goiters. You should try radioactive, no suspicious nodules and all that. 2, you very rightly pointed, after surgery recurrence, radioactive iodine ablation is the norm. You should not go and operate again. These are classical indications, small goiters, and if the patient is not even fit for a haircut, that means not fit for anesthesia, or patient doesn't want surgery, then you should go for radioactive iodine ablation. And remember,
solitary toxic nodule, but that will come under the secondary hyperthyroidism.
Yes.
We are talking of primary, Rohit.
And remember, 80% only will be cured by one sitting. Sometimes 10 to 15% may require 2 sittings of radioactive iodine. Very rarely 3 sittings, but 80 to 85% will be cured. And when you give radioactive iodine, remember this is a very important point. Your aim is not to make them euthyroid. Your aim is to make them hypothyroid. Why? Because if you partially ablate the thyroid gland, if there is residual functioning thyroid tissue, remember, remnant thyroid can later on predispose to malignancy, especially in the children. That is why you want to fully ablate the gland when you are especially giving it in younger people. Your aim is to make them hypothyroid and not euthyroid. There should not be any functional thyroid tissue. Okay?
Yes, sir.
The point here is that, Rohit, that radioactive iodine, once you give, if you see a long-term follow-up, the chances of develop of malignancy after 20, 25 years are definitely there. So if any remnant issue is there, it will definitely likely to develop this. Madam, you were saying something, Nina?
That is the disadvantage of this radioactive iodine. Patient requires regular follow-up. In thyroidectomy, surgery is done, do not require regular follow-up. They can consult nearby doctors. So in our country, if compliance is low, the surgery is the better option.
In fact,
Yes,
you are
sir.
absolutely right. Now, I'm not saying because I am a surgeon, there are enough studies now to say the best quality of life is after surgery rather than anti-thyroid drugs or radioactive iodine, because there are two conditions which I will say after hyperparathyroidism and after toxic goiter. When you operate on them, they feel a sense of goodwill. A sense of what shall I say, a well-being. That is immediately after surgery. So there's the evidence to say, but I don't expect the postgraduate to tell that in the exam. But this is just for knowledge that, as Madam rightly said, that surgery definitely improves the quality of life immediately. It provides controlled hypothyroidism. 3, you have a biopsy and you're definitely sure it is not malignancy. 4, you don't need to worry about pregnant. You can immediately get pregnant if you want. These are some of the what shall I say, what is perceived as advantages of surgery. And if you're doing surgery, total thyroidectomy, no hemi, semi, quarter, partial. They say total or near total, but I would say total thyroidectomy. Okay.
Sir, sorry to interrupt. Absolutely right, but actually he was on investigations when everything went on to radioiodine and complications of methimazole. We are still something pending about the investigation. He went only up to thyroid profile.
We'll go, sir.
What else would you like to do? You said thyroid profile and on thyroid antibodies, and there was some discussion regarding the medical management. Any other investigation you would like to do?
So in this patient, I have done ultrasound neck, and I would not like to do the any functional scan in this patient.
Okay, anything else in grateful?
Sir, preoperatively indirect laryngoscopy or serum calcium.
The genetic study, pa?
So, there's no family history of any thyroid illness in this patient.
What are the genetic studies you know about it? If the patient suppose his relatives have the same thing, what are the genetic studies you do? What mutations?
In patient with HLA DR3 and DR5, there is predisposition of Graves' disease in the family.
What mutations?
Sir, you explain because he do not know.
Please, madam,
Yes,
you
sir,
can
please.
you can elaborate, madam. I have limited knowledge.
Because we
Urmila,
do not
can you-
get genetic study. We do not get genetic study.
Urmi
Urmi,
madam,
madam.
anything on your side because on
Urmi,
this
madam.
particular
RAF,
I also know very little about the genetic cause of this
you can do
thyrotoxicosis.
RAS mutation study.
Yes, sir.
Okay.
Ritesh bhai, anything on your side regarding genetic studies? Because Dr. Vithal is busy with a phone, I suppose.
See, we are dealing with the Graves' disease, so we should not complicate the matter so much by doing the genetic studies. The treatment is and the management is straightforward, simple.
Not needed,
So,
sir.
not needed in this case, sir. And
Okay.
what gain we are doing to getting after doing the genetic studies, they are quite costly. And usually the RAS testing, if you want, it is better done on the histopathology sample after surgery. And the RAS panel costs around 15,000 in a hospital setting, sir.
I know that. I just wanted to him to know.
Yes, sir. So
That's
there's
good.
no point in doing the genetic testing right now. It's better to do a simple measurement. What I would like to ask the presenter that what else medications you would like to start apart from antithyroid drugs like carbimazole or methimazole? Any other medications you want to give to the patient?
He
So
said propranolol.
tablet propanolol 40 milligram 4 times per day.
4 times per day. You know what is the maximum dose of propranolol?
OD or BD?
So
What
sorry,
is the, my question is clear. What is the maximum dose of propranolol?
sir, 160 milligram.
Better 160 you are already starting. So
Yes.
the maximum dose of propranolol is 320, but do not give more than 160 because what happens at this dose, there's a very high chance of cardiac depression. So don't indulge into so much high doses without any expertise.
Yes.
It is better to start with a low dose, 10 mg or 20 mg once a day or twice a day. That will be sufficient in the initial days. So don't indulge in starting with 40 mg. QID is very, very high dose.
Yes, sir.
Okay. And
yes.
What other medications you know which control the hyperthyroid functions? Apart from beta blockers, that is propranolol, apart from antithyroids, what are other medications which you know which can be given? Not in this patient, but which can be given in hyperthyroid patient.
For lithium.
So if you want to give lithium, then what is the dose?
Sir,
Have you ever used lithium in the hyperthyroid patients?
no, sir, I haven't used.
Okay. So lithium usually is given in doses of 300 mg TID.
Yes,
apart from the lithium, what else?
Sir, steroids.
Okay, good. And anything else?
Sir,
one very common medication which is not available nowadays.
So Lugol's iodine.
Good. So Lugol's iodine is combination of which medications?
Sir, 5% iodine plus 10% potassium iodide.
Do you know how it is made?
No, sir.
Okay. So first dissolve potassium iodide in water. It makes the potassium and iodide ions, and then only you can dissolve the iodine crystals. If you will dissolve the iodine crystals directly in water, it will not dissolve.
Yes.
Okay. Any other iodine formulation you know apart from Lugol's iodine?
No, sir.
It is known as supersaturated potassium iodide solution, SSKI.
Yes.
Okay. One common
Ritesh?
thing that yes, sir.
No. You're very right regarding Lugol's iodine, but I will not say it is not available. Your friendly pharmacist will still give you.
Yeah. We have to
Yes.
prepare it, sir.
Yes. We used to, since our residency, we used to go to a chemist and he used to prepare it for me.
Yes.
In last
Even now,
5 years, it is not available. Previously, we used to give. Apurva will tell that he has also gone and prepared.
Yes, sir. Yes, sir.
yes.
I
So
had been to that place, but
either
now
use like Dr. Ritesh Agarwal said, either Lugol's iodine, which you rightly pointed, but most important, whatever you use, Lugol's iodine, how many drops? 5 to 7 drops, 8 hourly for a maximum of 7 to 10 days. That's the most important. Normally, I will not use it more than 1 week. Why? Tell me that.
why,
Why?
Rohit?
Yes, why?
After 10 days, there is a escape phenomenon, which can lead to the thyroid storm.
So before that, why do you give iodine? That
Sir,
How does? According to me, iodine will promote increase in thyroid hormone synthesis. But you're telling me for high thyroid, give iodine. You're confusing me now.
Sir, in Lugol, so in case of thyrotoxicosis, we give a high dose.
Not
iodine.
thyroid, hyperthyroidism.
So in case of hyperthyroidism, high dose of iodine, it leads to the inhibition of the organification and release of thyroid hormone from the thyroid.
Yes, 3 stages. It inhibits the transport of iodine into the cells. So decrease iodine. 2, it inhibits the organification. 2, 3, it inhibits the release of the pre-stored hormones. So because of all this, there's decreased thyroid hormone. But all this is only for 10 days. Then, as you rightly said, there's a escape phenomena. What is this phenomenon called, when you give iodine and there's decreased hormone? There's a name for it. You would have read
Very
it
good
in
name.
Ganong
Wolff-Chakoff
physiology.
Wolff-Chakoff effect.
Yes. Administration of high dose iodine leading to inhibition of organification is called Wolff-Chakoff effect. Some eccentric fellow like me comes, first thing I may ask you that. Okay. Luckily, you don't have me as an
what is the
example.
common name for this phenomenon? Thyroid constipation.
Constipation.
Pankaj Modi, sir, can I just take leave, sir? Because I think they're calling me.
Yes. Okay, we will just finish. Please, thank you very much for
Yeah.
your
Thank you, sir.
Thank
Thank
you
you for
all.
joining.
Pleasure. Thank you,
Thank you.
Apurva
It was a
sir,
pleasure.
Srinivasa,
Yeah.
Madam,
Thank you, sir.
Ritesh,
you.
thank
Thank you.
you. Bye.
Thank you.
Thanks,
Bye.
sir. Bye.
Okay.
Sir, thank
Sir,
you, sir.
investigation. We are
Pankaj
talking
Modi,
about.
sir, thank you. Thank you.
Urvi madam, you have any inputs for that?
When
Anything?
will you use iodine? I want to ask.
Modi, sir, thank you.
Thank you, sir.
Thank you.
Thank you, madam. Thank you. Thank you, Apurva,
Thank
sir.
you very much.
Got to go out for a function.
I read
Seven
about it. Yes, sir. Thank you very much.
Thank you.
When will you give? Madam's question is, when will you give this glucose iodine?
Timing of giving.
7 to 10 days prior to the surgery.
Yes, it is for the preparation of surgery. We give glucose iodine.
If you go in little detail, Rohit, when this Wolff-Chakoff phenomena or the constipation occur, there is excessive deposition of collagen material inside the acinine, which cannot go out. So they will distend the acinine, and it is said it makes the gland more firmer and easy to handle when we are doing. If we are talking of old era, when the energy source and the anesthesia, and they were not, hypotensive anesthesia was not there. So surgery was little meshy. So that's why this was, nowadays it is usually not used for these reasons.
Yes, sir.
But it is also reducing, sir, vascularity of the gland also.
That's what I am making it firmer, and that is the point.
So the surgery will be easy because of that.
That is the point. Distension causes the vascularity to lag. But previously we were very much worried. Nowadays we are at
We are
age with
having
energy
bipolar.
sources.
We can control.
Yeah.
And another point in Lugol's iodine is that it is actually unpredictable, as the sir has said.
Yeah.
That is why. And the preparation is very messy and difficult. So the use is now almost discontinued. We had used before 3 or 4 years in last case, as if I remember. I got it from GCRI also. That department also still makes Lugol's iodine. I don't know about some lab test. That is from there we got it. Yes.
We physicians usually say that we add fuel in fire while we are giving glucose iodine.
Okay. Right. Okay, Apurva, anything else?
No, sir. Actually, we were just on to investigation. Actually,
Oh.
we are talking about serum calcium and IDL. આપણે સાહેબ સાઇડ બ્રાન્ચિંગમાં રેડિયો આયોડિન પતી ગયું, મેડિસિન્સ પતી ગઈ, સર્જરી બાકી છે હજી.
Okay. So, did we discuss one important investigation, thyroid antibody?
Yes.
Yes, sir. Dr. Vittal has also given his inputs regarding the
Okay, then it is fine. Nothing is remaining. Surgery part. Which surgery you will do, Rohit, now? Madam, you can ask that.
Total thyroidectomy.
What do you mean by total thyroid? What is the difference between near total and total thyroidectomy?
Apurva, I will have to leave. I have to go to Epic for a function.
Yes, sir.
Thank you, everybody.
Thank you, sir. We'll continue.
Ma'am, in near total thyroidectomy, we preserve 1 gram of the thyroid tissue to keep the functioning thyroid gland.
So is it for functioning thyroid gland, or the idea of near total is something different? Is it to preserve thyroid gland or something else?
So that patient will not go completely hypothyroid.
No.
Anything else you want to preserve? Anything else you want to preserve?
So to preserve the parathyroid gland.
Yes.
So tissue around the yes, madam. Continue.
Yes, madam. Vijay, ma'am.
Yes. Is it being done that near total thyroidectomy in a Graves' disease?
No, ma'am.
No. What is the reason? If at all you leave some amount of thyroid tissue, it is not for the sake of the functioning, but to conserve the damage to the nearby structures like the nerves. Okay, so the parathyroid and the nerves has to be preserved. So if at all it's very nearby, we try to preserve it and leave a little bit. That's all. Otherwise, it is a total.
Yes, ma'am.
So basically, the thing is that because we used to do this, I used to do a lot, and I have seen my teachers doing a lot of subtotal thyroidectomies. The concept of total has come basically because of the very high chance of recurrence when you leave some thyroid tissue. And number one, even Dr. Ritesh would say that there are so many good gadgets available nowadays with endotracheal tubes having nerve ending this, that, and all those things. But basically, if you are good in a good technique of doing surgery, total thyroidectomy with preservation of parathyroids and the recurrent laryngeals is a good thing. Nowadays, preferably near to total thyroidectomy does not have any place as far as toxic, Graves' disease is concerned.
Yes, sir.
So,
Shall I?
Yes, yes,
yeah,
sir.
yeah.
Okay. See, and nowadays total thyroidectomy is done. However, with the old teaching, the old surgeons are still performing subtotal or near total thyroidectomy. It is better to do a total thyroidectomy, remove all the functioning thyroid tissue, whatever you can during surgery, make the patient permanently hypothyroid. And we have seen there are a large number of studies, many studies, and number of studies actually, I should say, we have done a meta-analysis also, that after doing a subtotal thyroidectomy or a near total thyroidectomy, there are some complications like recurrences, not immediately, but after many years, maybe 10 or 15 years down the line, or chances of malignancy, development of malignancy in the formation of nodules, which have occur in the remnant tissue. So there are, plus people leave the remnant tissue thinking that, people leave the remnant tissue thinking that the nerves and parathyroids are preserved, but actually we have found that the damage to the nerves and recurrent laryngeal nerve is more when we leave the tissue as compared to do a total thyroidectomy. So total thyroidectomy is a safer alternative in by any means with compared to subtotal or near total thyroidectomy.
Okay, during surgery, if you find out there is some tracheomalacia, what measures should be taken in that patient?
Trachea is a very hard structure. We think that tracheomalacia will be there, but usually it is not there even with the huge and large goiters I operate. So what we do, that if I found trachea, the ring usually if it is flaccid on one half only, not on both sides. So if it is flaccid, if it is sinking down, so I tell my anesthetist during surgery to deflate the cuff, take out the endotracheal tube till the vocal cord. I will palpate with my finger the trachea, whether it is flaccid or hard. If it is flaccid, I will usually take the Vicryl 20, just take the periosteum and a little bit of cartilage tissue of the trachea and join it with the sternocleidomastoid muscle tightly so that the rings do not get sink in when the patient is extubated. And it usually helps and rarely required. I have operated so many number of huge goiters, not big but huge goiters, and tracheomalacia is a rare thing actually. So we think tracheomalacia will be there, but usually it is not there.
So in case there is any doubt, Rohit, patient should be kept intubated for 24 hours. Patient should be kept for on ventilator for 24 hours. That will suffice. And later on, if patient is not improving, then patient may require tracheostomy. Right? But as sir has said, Ritesh sir has said, it is better to hook it with the sternocleidomastoid. So there will not be inspiratory stridor. Patient will develop inspiratory stridor specific for this.
So one question from this: what is tracheomalacia? What is stemmar trachea? And in which patients you are likely to see such features, and how do you diagnose it?
Sir, tracheomalacia is due to the long-standing large goiter. There will be increased vascularity, which
is it goiter or something else? See, goiters are not hypervascular.
Yes, sir.
So it is Graves' disease. It's a thyrotoxic or a hyperthyroid patient with lot of vascularity, which washes the calcium away. That is what the theory is, right?
Yes, sir.
Okay. And what is the difference between two? And can you a simple test to identify?
Sir, Sir, for tracheomalacia,
Yes.
uh, tracheomalacia is diagnosed intraoperatively when we palpate the when we take out the ET tube, or when we palpate the tracheal cartilage after the thyroidectomy. And so in case of scabbard trachea, there is a tapering of the trachea due to the large lateral.
Is it tapering or it is deviation?
There is
Ritesh bhai, what is your take?
See, tracheomalacia, the rings are actually the cartilage framework loses its hardness and becomes soft. Scabbard trachea is a different thing where there are three components. The most common component of any thyroid swelling leading to towards tracheal abnormality is a deviation. Due to pressure effect, trachea gets deviated to other side. Second component is the twisting of the trachea. And third component is angulation. So scabbard trachea has all the three components: deviation, twisting and angulation. आपने डॉक्टर रोहित, आपने कभी जो है इसका तलवार देखी है ना, तलवार की म्यान जिसमें
Yes, sir,
तलवार
yes,
रखी
sir.
जाती है?
Yes, sir.
सो जो तलवार की म्यान का आगे से टेपरिंग एंड होता है, दैट इज
Yes,
नोन एज स्केबर्ड ट्रेकिया. व्हेन यू सी ऑन एक्सरे, इट लुक्स लाइक अ तलवार की म्यान. जो आगे का पॉइंट होता है, दैट इज अ फुल्ली टेपरिंग एंड. And those are real surgical emergencies, and you should try to operate as early as possible because patient may go into respiratory arrest anytime.
Yes, sir.
And after surgery, when you remove the mechanical compression, usually the trachea comes in the normal location.
Yes, sir.
In those
So what
cases, you don't need to do
complications can
anything.
occur after total thyroidectomy?
Yeah.
Immediate complication, there is a hemorrhage, and there is voice change due to the damage to the recurrent laryngeal nerve, and aspiration.
Anything else regarding voice damage? Only recurrent laryngeal or something else also?
And so external part of the superior laryngeal nerve, it can lead to the low pitch voice. Patient is not able to speak in high pitch. And late complication, there can be hypocalcemia due to damage to the parathyroid. And
how you told it is a late complication? How late it is?
It is seen after 5 days, 4 to 5 days.
Na beta. Hypocalcemia
No.
is seen after 24 or 48 hours. Most commonly after 48 hours.
Yes.
So
And
you
then-
will not discharge patient in total thyroidectomy immediate after the surgery. In hemithyroidectomy, you can discharge, but in total thyroidectomy, you have to keep patient admitted for 48 hours because patient may have hypocalcemia, right?
Okay.
Within
So
48 hours.
Yeah. Suppose now let's talk about some newer things. If you want to
Okay.
discharge the patient within 6 or 12 after surgery, after doing total thyroidectomy, so what are the
You can have
parameters?
parathyroid hormone assay immediately also, right?
Yeah. So what are the parameters you will do to decide the discharge level, whether the patient can be discharged safely or not? After surgery, what will you do to decide? Which test?
So serum parathyroid level.
At what time? After surgery, how much time?
So immediate after surgery, I can do the
No, but
parathyroid.
it is 4 hours. So after 4 hours, if you do the serum PTH and if the PTH comes in the normal range, then you can assume that PTH, the parathyroid glands are not damaged, and the
Yes.
patient will have no significant hypocalcemia. So you can discharge the patient very well on oral supplements of minimal doses of calcium and vitamin D.
Yes.
It is being followed in America, and in those hospitals where there is a crisis of the bed, so they try to discharge the patients early, and by doing the serum PTH after 4 hours, it is known as Q4 PTH.
See, in hyperparathyroidism, we get the report done on table, but for thyroid surgery, it is done after the surgery, not during the surgery, right? Because here the parathyroid is not hyperactive and rest of the parathyroid are not suppressed, right? Okay.
Madam had asked regarding complications. You have not stated one very important complication. You said immediate and late. What about the middle period when the patient is in a ward?
So tetany due to the hypocalcemia.
अरे वो नहीं, उसके पहले यार.
Sir, hemorrhage
So yes, so post-operative hemorrhage in the ward
yes, sir.
where you have closed the strap muscles can lead to compressing hematoma,
Yes, sir.
right? So it's a very important. Of course, I have touch wood. I have been lucky that I have not seen the complication. But what I have heard is that you need an immediate evacuation, and the patient becomes, I mean, the patient gasps for air.
Yes, sir.
So will not wait till patient is breathless.
Yes.
That is important. You can't see even the swelling because strap muscle is closed. So how
Yes,
will you diagnose this patient is bleeding or there is hemorrhage?
Ma'am, there will be swelling around the stitch line.
No, because there is this muscle, step muscles are closed. There will not be swelling.
So, ma'am, patient will have difficulty in breathing. Stridor.
You will not wait till that. In between, more drain output. You have kept the drain, and so there is a more drain output, and you find out ecchymosis, little bit ecchymosis. So immediately you take patient for the or get the USG if required on the table. Shift patient into the OT, not into the ward,
Yes.
and you open up the stitches under anesthesia, not without anesthesia. Right? Okay.
Yes, ma'am.
Any inputs on your side, Ritesh, regarding post-op hematomas?
We should be very careful and meticulous during dissection. If we are meticulous during dissection, the bleeding will not occur. And one more thing, students should learn how to tie the knots, especially on the poles. It's very important. Every student should make this a habit of tying the knots. This is art. Learn this thing, hematomas will not occur. One important thing is when you are dividing the strap muscles and then closing them, be very careful on the posterior aspect, because one of the most common place where this hemorrhage occurs is the posterior surface of the strap muscles. Rather than poles, the posterior surface of the strap muscles is more commonly getting hemorrhage. So be careful while you are closing them.
Yes, sir.
How will you see for T10?
Yes, ma'am.
Test for T10
Ma'am,
before patient develops T10.
ma'am, we will look for the Diagnostic sign and Trojo sign. In Diagnostic sign, we tap on the infraauricular region from where the facial nerve comes, and we will look for the twitching of the facial muscles. And in Trojo sign, we will when we will put the sphygmomanometer cuff around the arm, and we will raise the systolic blood pressure till the 200 millimeter of mercury, and we will look for the carpopedal spasm.
Now,
Okay.
and just a minute, let me further clarify it. See, Shostak and you told infraauricular. It is not infraauricular. It is just below tragus.
Yes.
Okay,
Yes.
just below the external auditory meatus. When you tap there, then the twitching occurs. That is the Shostak sign. Second thing, you do not lead the cuff pressure to 200. You know that if you tie your own the sphygmomanometer on your own arm and make the blood pressure 200, you yourself will develop tetany. So don't do that. It
Yes.
is 20 millimeters Hg more than the systolic blood pressure. Suppose the BP of patient is 140, so you make it 160.
Yes, sir.
That is a better idea rather than 200. At 200, every person will get tetany. You will get a latent tetany in the form of carpopedal spasm if there's a very high blood pressure without flow of blood. So better only 20 millimeters mercury more than the normal blood pressure, systolic blood pressure.
Yes, sir.
Okay.
How will you prevent injury to the parathyroid gland in thyroidectomy? Which steps to be taken care while doing the surgery?
If you don't know, say.
Yes, I don't know.
So when you are doing dissection anterior to the recurrent laryngeal nerve, right? So you see the parathyroid gland. So you just bipolarize these vessels, inferior parathyroid branches, rather than ligating inferior parathyroid main artery, right? That will help to prevent the blood supply to the parathyroid gland, as well as a vessel which runs posteriorly, which is communicating with the superior thyroidal artery and inferior thyroidal ascending branch. That is to be preserved. So branch coming from that vessel, supplying the superior thyroid, superior parathyroid will be preserved. And so both the parathyroid will be preserved, right? So take care of parathyroid by that. Take care of the blood supply to the parathyroid by that means, right? Use bipolar as far as possible.
A better idea would be that use any forceps, whatever you are using, either mosquito artery forceps or mixture forceps. Make a plane and just besides thyroid capsule, just hug the thyroid. Whatever structures you are encountering on the thyroid surface, just keep on dissecting them and dropping down on the lateral side. Make the thyroid medially, so you will save the parathyroids and you will not enter into any zone of parathyroid vascularity if you are remaining between thyroid and parathyroid. So because the parathyroid vessels are coming from the lateral side, not from the medial side. So if you are between thyroid and parathyroid, then definitely you will save the vascularity and there will be no permanent hypocalcemia.
Yes, sir.
How will you treat the patient if patient develops hypocalcemia?
If patient develop
Two questions. One is if you accidentally come to know per-operatively that we have lifted the parathyroid, and second is what made have said, the postoperatively if you find out that you have removed the parathyroids.
sir, if patient develop the signs like perioral, there is a complaint of perioral numbness, there is a tetany, carpopedal spasm is present. I would like to do the serum calcium level, ionized calcium level, and if it is low, I would like to give patient IV calcium gluconate.
But why you want to do ionized calcium along with total calcium? I think total calcium is sufficient because it is the ionized component, which is the active component. It depends upon serum albumin. So if serum albumin is usually fixed thing, why you are doing ionized calcium again and again? Number one. Number two, why you are starting on IV calcium gluconate? Why not oral calcium medications first? First give oral. If they are not controlled with oral, then give IV.
Yes.
What is the dose for oral?
Calcium? How much of IV calcium you are going to give?
Yes,
if there is a spasm?
Yes, ma'am.
How much we will give?
1000 milligram per day of oral calcium.
Do you know how much one vial of calcium gluconate, the elemental calcium, how much is there in one vial of calcium gluconate? Have you ever seen?
So in calcium gluconate vial, sir, there is 2 grams, sir.
2 grams? Are you sure? Calcium gluconate vial is 10 ml. Yes, calcium Sandoz vial is 10 ml. So per vial, how much calcium is there in every ml and total?
Sorry, sir, I'm not sure, sir.
Okay, so it is 9 mg per ml. It is in mg, 9 mg per ml. Do not say it is 1000 milligrams per day. 1000 milligrams is the oral physiological dose. But if you are giving IV, it is already bioavailable. So you have to give lesser dose, na? If you are giving more dose, you will land the patient into hypercalcemia and then arrest also. Don't go into that thing.
Yes, sir.
Okay, so it is 90 milligrams of calcium in every vial.
Yes, sir.
So how much frequently will you give?
Ma'am, I would like to give 2 ampule in 100 cc NS over 30 minutes.
No. At a time, not more than 10 milligram is given. 10 ml is given. So at a time, you will give 10 ml. It can be given IV slowly or in 100 ml slowly, right? Yes. Over 10 minutes. And BD dose is maximum dose is BD. You can give TID, but most of the time BD will suffice. Simultaneously, you can give oral. You can start oral, right? If symptoms develops, then you can give again, repeat it again, right? Yes. Okay.
Anything else left out, madam? Ritesh bhai?
I think this will be sufficient for him today because he's already tired. He's tired looking for 2.5 hours now.
No, but it was worth.
Actually, smiling face. Yes, I am relieved. Okay.
Okay, then we'll leave,
That's
sir.
all.
Thank you for joining. Thank you, ma'am.
Thank you, madam. Thank you, Ritesh.
Thanks,
Thank you. Okay.
Thank you.
Thank you, everybody.